an idea before we start of how many of you are here for you, to learn information for yourself, okay? And how many are here for wanting to get information to help a family member or loved one, okay? And how many of you have an advance directive right now? Good, that's actually great. Hang on, I need to get back to the beginning of that. Okay, so, you know, when I was asked to do this talk, one of the main focuses is what is the difference between hospice and palliative care? And we're definitely going to talk about that tonight. But the main point of the talk is discussing choices. In the late 60s, when different forms of life support were really gaining momentum and technology was becoming much more advanced, there was an unspoken mantra: if we can, we must. And what's happening with the movement of palliative care is we're seeing more of a shift of patient-centered or patient-focused care that's based on your individual goals and values. We know how to prolong life. The question is, does it make sense and does it restore health? And for a lot of people, that's more of the goal, is restoration of health to the best that we can. We're going to touch on the current state of healthcare. Obviously, you can't open a newspaper without hearing something related to what's going on in healthcare. We'll talk about the difference between hospice and palliative care. We're going to touch on why prognosis is a really important part of making this medical care plan or creating your own personal map. And then Shada is going to be talking about the different ways that you can empower yourself to make sure that the decisions that you want to be made for you are made. So this is a patient. This is not really the patient, but this is the picture that captured this man in the best way. So Mr. H was a 96-year-old that I took care of. He had moved to an assisted living about 1 year prior to my meeting him. And he became extremely ill with urosepsis, or a bad urinary tract infection that not only landed him in the hospital, but he was in the intensive care unit with multiple organ systems failing. He was on a ventilator. He needed medications for blood pressure support. His kidneys and his liver were not doing well. And after about a week in the ICU, things were not looking up. And so a family meeting was held with the primary team, ICU team, and the decision was made that perhaps this really wasn't in line with what this man would want for himself. And at that point, the decision was made that maybe we just focus on keeping him comfortable and allowing his death to occur. We had all of these machines, his body was dying, but there was this thing in the way that wasn't allowing him to die. So the decision was made was, yes, we're going to focus on comfort. And the next morning, lo and behold, all the numbers started improving. He needed less oxygen, his kidneys were looking better, he didn't need any blood pressure support, everything looked like it was turning around. So the decision at that point was, well, maybe we should stay the course. He's actually getting better. And within another week, he was actually off all life support. He was on the general medical floor with multiple complications from being as ill as he was in the ICU. But he eventually made it out of the hospital to a skilled nursing facility for rehab. After 2 weeks in the rehab, he wasn't able to participate. He wasn't able to do the 3 hours a day that you need to do to have Medicare cover this benefit. So they were in another conundrum. He's too sick to go back to his assisted living, and he can't go home because there's no family member to take care of him. So the only option was long-term care in a nursing home. The family knew this wasn't what he would want, but there were no other options. And by the way, this is usually around $8,000 a month that's out of pocket for families. 5 months later, he developed a pneumonia and he died in the hospital. Now this is not meant to be Debbie Downer, but unfortunately this is often the course that occurs. So was this a successful final chapter? Does anybody have any opinions? I mean, would you say yes, this was? No. It's funny. There are some people who say, yeah, that was. Well, it really depends on your perspective. So if you're the physicians taking care of the patient, and I remember this when we would get a patient who was very sick alive to discharge, that felt like a real success. To the hospital, absolutely, because the patient not only survived to discharge, but they didn't readmit within 30 days. That's their big quality measure. To the payer, not so much. It was $120,000. But what's the important piece that we're leaving out here? It's the patient. We don't know because we didn't ask. We didn't have those conversations before the emergency occurred. Family members have a very difficult time making decisions for their loved ones when they've never talked about it. So I'm going to give you two scenarios. By the way, Mr. H happened to be the second one, but we'll go through the first one too. Mr. H wanted to go to his granddaughter's wedding, and he was able to go. He went in a wheelchair, but he got that first dance with his granddaughter. And so that whole experience, the 3 weeks in the hospital and attempting rehab, was worth it to him because he got that piece. Mr. H number 2, which was our real Mr. H, he was ready to die. He had been ready to die for quite some time. He didn't want to prolong this process in any way. And it really created quite a painful exit for him. There is a tipping point that is completely individual for every single person in this room. Prolonging life versus prolonging death. And for Mr. H, prolonging his death occurred when he lost his wife and he moved to an assisted living. So here's the important part, and this is the part that brings us geriatricians joy in our work. He'd been married 58 years and he'd lost his wife a year ago. He'd been the CEO of a huge company. This was someone who was used to being in charge, and he'd lost that. He'd had a lifelong love of learning. He was like all of you who are at community lectures, auditing courses at the university, up until he was 80 years old. He moved to the assisted living, as I said, after his wife died, and he had 3 really great kids. What he valued was his functional independence and his ability to think clearly. That was what was most important to him. He really felt his quality of life was poor. He missed his wife terribly, and he was ready to die and be with his wife. But there was no conversation that occurred, and so no one knew what he wanted. Okay. So what percentage of Medicare recipients die at home? Now, thankfully, these numbers are going up. In 1989, it was only 15%. 2007, 24%. And 2009, 33%. So we seem to be making progress. So why is that considered progress? And that is because the vast majority of Medicare recipients report that that's where they want to die. I'll tell you about Monty Hall in a minute from Let's Make a Deal. But what percentage of Medicare dollars are spent in the last year of life? And this is one I actually want to get some input. Throw some numbers out.
80%.
80%?
40.
70%.
70%?
85.
Wow, you guys are, it's actually 27%. But when you think of how, if the average length of life is around 80 years old, that's a huge chunk to be spending in that last terminal year, really. 18% of the total expenditure, so not just the medical, but that's out of pocket for families, and that's a huge burden. Only 2.8% of Medicare dollars are spent on hospice. And in a Robert Wood Johnson study, they found that hospice would save about $2,300 a patient. Now, the money's not the issue here, as you know. There are a lot of patients getting a lot of care that they may not want at an astronomical cost. And a lot of that is that we just don't talk about it. The palliative approach in patients, the reason this fits in with palliative care and hospice is that's what palliative care does. It looks at the big picture. It looks at the patient as a whole person within their family unit to determine what brings someone joy. You see this little ball rolling down the hill. Well, if you think of an illness, a chronic illness, that's when the ball is at the top of the hill. It doesn't take much to stop it from rolling. You put a small intervention in front of it with minimal morbidity and they do okay. Once you reach the middle of the hill, the ball's picking up momentum, and it takes larger interventions that probably have more negative side effects to slow it down, and you may not be able to stop it. At some point, it's going to reach a terminal velocity, and that's when someone is in the terminal phase of their life. And you can throw all sorts of things at it, and that was Mr. H, but it's not going to stop that process. Now back to Monty Hall. So Ira Byock is a wonderful palliative care physician at Dartmouth-Hitchcock, and one of his books that I've loved is called The Best Care Possible. And he talks about how we kind of have, like, you know, sometimes door number 1, 2, and 3 as your exit. Okay, so door number 1 might be something like pneumonia, or for our gentlemen, a urinary tract infection. And that can be a relatively gentle exit. But if we block that door, we get what happened with Mr. H, which can be a much more tumultuous exit. Okay, so here are some generalizations about our medical system. It is progressively more compartmentalized. Very evidence-based, but the problem in geriatrics is that you look at these studies and they exclude everyone over age 80. So it's very difficult to apply these evidence-based studies for this population and assume you're going to get the same positive benefits. As we know, there's a lot of defensive medicine going on. People are afraid of getting sued if they don't strongly encourage the most aggressive form of treatment. We are way overly optimistic in our prognostication as providers. So that's on us. And what was interesting, there have been a couple studies on this, but the more the physician knew the patient and the family, the more overly optimistic they were. And you can see how that would happen with people you really care about. Excuse me. It's harder to see the forest through the trees. And there's huge time limitations. So if you have somebody coming in to talk about their diabetes and their hypertension, sitting down and having this conversation, it's very difficult to fit into a 20-minute visit. So it really isn't set up to have these discussions. We will empower you to figure out how to fit these discussions in, by the way. So palliative care, what is it? So it's specialized medical care for people who have serious chronic illness. It aims to relieve suffering. It looks at the patient within the family unit and treats the whole person and the whole family. The goal is to improve quality of life without so much of a focus on life-prolonging treatments, although those can be pursued concurrently. And it's provided by a team of doctors, nurses, and depending on the program, ancillary services that work together with the patient's primary care physician to provide really an extra layer of support. And it's appropriate at any age or stage of illness because we'll go over a little figure that demonstrates that. So if you think of palliative care as the umbrella, and there are a lot of things underneath that, you can have inpatient palliative care consults, you can have outpatient palliative care consults, home-based consults, or hospice, which is also under that same umbrella, but the focus of hospice is entirely comfort approach. So hospice is actually, unlike the first three that we talked about, the different types of consults, those are just regular Medicare Part B types of insurance, where you would go see your doctor and have it billed to insurance, and you may have a copay. That's how that's set up. Hospice is a shift over to Medicare Part A, and it's much more regulated. So it's a defined, integrated model of palliative care. It can be as aggressive with a different focus, the focus being on someone's comfort or quality of life, repairing relationships, things that are bringing suffering to that person. And it aims to relieve suffering, as both of these are. So prior to palliative care really being in place, you had curative treatments that would go until curative treatments were no longer working, and then they'd say, well, now it's time for hospice. You can imagine the sense of abandonment if you've been working with an oncologist for 5 years and you go in and they say, sorry, there's just not much more we can do, we're going to refer you to hospice. A whole new team of people that don't know you. This is the best care possible. At the time of diagnosis of a serious illness, that's when the team should be in place. And as you can see, if you go through time, as illness progresses, there becomes more of a focus on how can we improve your quality of life, and sometimes the side effects or the negative effects of the treatments start to outweigh the benefits. When you get to the very end, when the curative treatments are not having their desired result, typically with palliative care involved early, that transition becomes much more it's seamless, and there's less sense of abandonment. So they're similar. Ideally, they're both interdisciplinary, although because there's no regulation on the palliative side, you don't always see that. They're holistic, they're patient-centered, focus on quality of life and symptom management. But these are the differences, and these are important to understand, because in palliative care, it's for chronic illness, and you can still pursue all the life-prolonging treatments you want. There's no eligibility criteria, and as I said, it's a part of Medicare Part B. Hospice is for terminal illness, and we say prognosis less than 6 months. There are people who are on hospice for 2 years, because at each interval, if the hospice medical director can say, I still think their prognosis is less than 6 months, they stay on. It's not like you use up your days and that's it. And that is a Medicare Part A benefit. So we kind of use the term palliative approach to patients, and I very much do this in geriatrics. They kind of merge together, which is determining what someone's care goals are, what is important to you as a person, and that becomes your guiding light for all medical decisions. And we're going to kind of go through how you put together this medical care plan. The goal is to improve life, quality of life through symptom management. And then the other big piece is helping family members prepare for what might come, so they can hope for the best, but prepare for the worst, so you're not trying to make emergency decisions. And obviously addressing suffering is a huge part of this. What I have found in the last 3 years of doing almost exclusively geriatrics is that the primary source of suffering, and this was so true for Mr. H, is losing control. There's a sense that they're kind of on this roller coaster and they're not involved in decision making. And sometimes you'll even see that happen where physician or provider will start talking to the family more than the patient. And that can definitely reinforce that feeling. So what are the components of, we're going to talk about this medical care map. The first and most important thing is your destination. And that's your goals. That's what we're trying to get to, or what we're trying to preserve. There's the mode of transportation, which is your prognosis. What are you driving? Are you driving the Tesla, or are you walking? And that's going to help also guide those decisions. And then there are the highways, the roads. How are we getting there? So as I said, goals and values are the destination. And it's really getting at, what do you as an individual or your loved one, what do you value? What are we trying to preserve? What brings you joy in life? And that's usually a really common opening question. And what are your goals over the next 6 months? That gives a lot of information, and these are things you can ask your loved ones that may be a little closer to this stage. They usually kind of fall into 4 major categories. Preservation of physical function, that was Mr. H. So being able to, some will say, well, it's golfing. But they may at some point say, well, I get that I'm not going to golf anymore, but I still want to be able to dress myself and bathe myself, and those things that are really important as my, to keep that sense of independence. Preservation of cognitive function, again, that was Mr. H. Lifelong love of learning, and he felt that he just couldn't process the way that he did. Preservation of relational or ability to communicate. That will usually be answered with, I really love being around my family. I want to spend time with my grandkids. And then there's preservation of heartbeat. And there are a lot of people that say, that's not a lot. There's a small minority that want to be kept going at all costs, and that sometimes is a religious belief. It can be just, I'm not a quitter. I often will hear that, I will not quit. So, prognosis is kind of one of those touchy subjects because we don't have a crystal ball. And there is a perception, which I'll go over, that maybe people don't want to talk about it. So understanding what a patient thinks is going on is a really important piece. And I think most clinicians will ask those questions. Asking how things have been over the last year. Is there insight into, if someone's been in the hospital 4 times in the last 4 months, is there insight that maybe things aren't going quite so well? And you can see we have the different modes of transportation, or the camel, and I should have had someone crawling or something. But okay, so what percentage of older adults want detailed information on prognosis? What would be your guess? Okay. 75. You guys are right on, 55%. Which, and that was done in 2012. So that's a pretty accurate. It wasn't done 10 years ago. So what's been shown? So 90% of oncology patients want detailed information, and granted, they tend to be younger patients that have, some of them might have young children, and there's a lot more need for planning, I guess would be the way of saying it. The 55% of geriatric and 80% of all comers. They want to hear it typically from the provider who knows them best, or the experts, that could be the oncologist or cardiologist, and they want to understand their choices. And this allows setting of realistic goals. Otherwise, you might not be preparing for things that may be coming. So what were the barriers to discussion? I thought this was a really interesting study that looked at a group of geriatricians. That was kind of the group that I focused on. And the barriers to discussing this were lack of time, definitely. You don't want to, in a 20-minute visit, say, oh, by the way, this is what I think. The fear of taking away hope. Discomfort with the discussion. It can be uncomfortable to discuss. And denial in patients, or perceived denial in patients. And then the longer you wait, if there is a level of dementia or cognitive decline, it can make these discussions difficult. So let me get an idea. How many would want to have detailed information about prognosis? Yeah. Good to know. That helps me too. So as far as determining, if you're looking at your loved one, getting an idea of when you might need to start making more plans, I guess, trajectory is really important. If you have someone, if you have a loved one who's been really in a wheelchair for 2 years and there's been no decline, that's actually very helpful information versus someone who was playing golf 6 months ago and now they're wheelchair bound. So that will give you important information. It does get easier to figure these things out as someone is spending more and more time in chair or bed. And a couple of important things that you can ask for, which is have your doctors all talk to each other. So there's a unified message. So that's an important piece. And typically this is discussed in terms of, on hospice, sometimes it might be even hours that you're talking, days, weeks, months, and years. So obviously this is going to help people make plans, life review, reconnect with the people that they love. So the medical decisions, these are the roads, the highways, the flight plan, depending on how you're going. And if you have someone who is, I'm going to use Mr. H, for example. So he's not in a wheelchair, but he uses a walker and he's having a really difficult time. If you have that person and he says, I want to go to San Francisco, but I'm walking, it would be pretty important to tell them that that's probably not, let's try to get to something that might be more attainable. And if he's walking, you're not going to send him on I-80. You're going to choose a path that helps him to reach his goals. And that's one of the things that we all try to do, which is make sure that the medical care plan makes sense, that it's something that is attainable. So we kind of beat that one into the ground, so we'll skip that. Okay, so when I was a resident, and I don't know if this is true for you, but I remember going to admit someone in the ER to the hospital, and I would spend 45 minutes doing their history and physical, and on the way out the door I'd say, by the way, if your heart stops, do you want us to try to restart it? Like it was an afterthought. Like this is kind of an important part of the discussion, and somehow that was lost on me. But I've realized now that giving someone, here you go, here's your advance directive, fill it out. Information is important. If you knew that the expected outcome of CPR was that you had a 40% chance of survival and a really good chance of returning home to your normal level of function, that's one thing. What if you found out there was a 5% chance of survival and the chance of you returning to your current place of living approached 0? That might be some important information to have. We do informed consent for every procedure we do in medicine except CPR. So it's important, those are questions that you can ask your provider. Okay, so we talked about translating. We've got all this information. We have our guiding light. We know what makes you tick. We know your prognosis, and everyone's on the same page. Now let's make medical decisions that are going to support all of that. There's the map that's created, and it represents you as a person. So, Shake's going to...
So I remember Jamie and I were sitting together in my office and we're thinking about these analogies of how can we sort of try to describe this process. And I loved, we kind of just brainstorming together, and this analogy of this roadmap came up. And we're like, this is brilliant. This really works, because the whole idea of your goals being the destination, I'm actually using this now when I teach the interns at the University of Utah, because we start typically when we're as doctors and we're asking people what they want, we don't ask them their goals or values, we ask them treatment options. So that would say, you know, just like Jamie said, if your heart were to stop beating and you were to stop breathing, would you want us to X, Y, or Z? So that's, to me, is the equivalent of saying, do you want to go on I-80? Do you want to go, you know, on a plane? Do you want to go on in a car? And never ask you where you're going. So it's sort of trying to get you on some routes without ever asking you your destination. And so we're really trying to teach people that the key question to ask first is what's important to you. That's your destination. So if it's really important to you, just like Jamie mentioned, to stay home, I don't want to live in a skilled nursing facility. That's not acceptable to me. Well, then there are some routes that I might recommend for you that would support that decision making. And there's some routes that I might not recommend because it doesn't support that. So we're really learning that the key question first is, and as you're looking to make these plans for yourselves or even your loved ones, what's important? Key question. And then just to elaborate, just like Jamie mentioned about prognosis. So if your destination is to get somewhere, like the Himalayas, you want to climb Himalayas, but you haven't even maybe like walked around the block at your house, that's kind of my analogy for prognosis. So prognosis is a reality. It's kind of our method of transportation. It's our, if we have advanced cancer and it's looking like it's not going to give us a lot of time, we also want to use that when we put our goals together. Are my goals going to be realistic? So I really am very excited about this map analogy because I think it really does work. And remembering, again, I think this might be important for me as a provider, and what I teach is goals come first. So now I'm going to kind of get a little bit into the nitty-gritty. You kind of have this idea of the components of what are important. And then you can start laying out a roadmap for yourself. What are the treatments that I want? With my goals, with what's important to me, the things that are important in my life, what treatment options support that and what things don't really fit in with that? And the idea of an advanced care directive, is that you can actually start to lay some of that out before it even happens. You can sort of map your trip and choose your direction before you set out on the road. So I wanted to give you a few definitions first of what these are, and many of you here might actually be familiar with them, but I'm hoping I might give you a little information that you may not already be familiar with. So an advance directive has two parts to it. There's a living will and usually a power of attorney. And in Utah, I think we've just passed out these handouts to you. With the advance directives that we have here, you can do a living will portion. That's the very back. And the living will portion has some different scenarios and some different ideas, and it lets you communicate what you would want in these different scenarios if they were to arise. So you're looking ahead, none of the situations are happening right now, but you're making decisions about the future. It's legal as soon as you sign it and it's witnessed, so it's legal. But it doesn't go into effect until you're not able to speak for yourself. So this is something I always have to remind our interns at the university, that you don't look at someone's document first, you talk with them. The document comes into play if they can't speak for themselves, then we look at the document. And so it's a good way to sort of map out some of your wishes in the event that you can't speak for yourself, and to sort of think ahead and decide. Can be very effective. And so again, there's a little difference between, and I apologize, I think my slide might have been out of order there, so I'm going to go to this one next. The other type of advance directive is a healthcare agent, and that's when you name someone that you think can really be a good advocate for you, to speak for you if you can't speak for yourself. And then there are a number of different legal terms for this that are on this slide. So it might be called a surrogate, a healthcare proxy, a healthcare agent. Each of these have different legal implications. And so I won't go into detail about that, but our lawyers in the group can really help us understand that depending on which title it is, they have certain rights and certain responsibilities that they can execute for you, and certain things that they can't do. So knowing which is important, because there are certain rights and responsibilities that those individuals will have if they serve in that way for you. And again, you can name whoever you think is best, and then they won't speak for you until the time comes that you can't speak for yourself. And that's really another important message, is if you're feeling that someone is going to your power of attorney as a healthcare provider and you're capable of making your own decisions, you can really try to remind them that it's important to speak to you. And the same if it's a family member. Sometimes younger medical providers tend to talk to family members in the room and may not go to the person, so that's an important reminder. So people raise their hands that they do have powers of attorney. Is that right? Pretty much if you have a power of attorney? Not? Okay. So now, this was really a good exercise for me, because I started thinking, I do too, I have my advance directive, and I think sometimes we pick people, and we may not really be thinking about what are the qualities of the right person to be in this role. And so here are some things that when you're thinking about who you've picked, now you can decide, do I need to revise my advance directive? So the idea is that you want to make sure it's someone who knows you and understands your wishes. So you have to make sure, one of the things is that we communicate our wishes to this person. But do they understand what's important to me? What are my goals and values? And do they understand that? Then the next part is that they have to feel comfortable making healthcare decisions that are according to your wishes, not what they would want for you. So this is where things start to diverge a little bit, because you might have someone who's wonderful, knows you well, knows everything, but gosh, I just, I can't let her just go. And so I think I would want a few more days, even though that's not what she said she would want. They'll make decisions for you based on what they want for you. So we want to take other people's wishes into consideration as we're making these decisions, but really what our goal is as the power of attorney is to be able to make the decision that the person would make, even if we don't quite agree with it. So that's an important factor to consider. The next thing is, so you might have those two things, and then the next part of it is, can they make decisions in a stressful situation? We're now Mr. H's family, and we're in the ICU. And let's say he's not widowed, and it's his wife, and she knows him, and she will honor his wishes, but this is going to be an enormous amount of stress for her, potentially, again, just hypothetically. So asking the person if they're willing to serve this way, and thinking about how are they going to respond in a really stressful situation, and will it be okay for them? Really important thing to think about. And then, of course, having the conversation. So I think these are some really important things to think about when it comes to everyone here. It seems like, not everyone, but very many people here have these advanced directives that are completed. So I would just ask you to think about it with this criteria and see if it still makes sense, or if there might be some revisions that you need to make. If you don't have a power of attorney, and for those who have not created an advance directive. This is the Utah statute that lets you know the orders of decision makers. And I think, will the slides be available for people? Do we know? I think that hopefully they'll be available, we can make them available to you, so all of these resources are here. The reason this is important is if you haven't named someone, this is the order of who Utah will go to. So at first, no matter what, if you've named someone and they haven't been disqualified, that's who will be asked. Even if you have a court-appointed guardian, as long as the person you've appointed has not been disqualified, our state statute says we'll go to that person first. So who you name is a very, very important individual. If you don't have one or two, if you haven't named someone, and most people don't have a court-appointed guardian, then it goes to your spouse. And as long as you're not divorced or separated or they haven't been disqualified for any reason, that's who the state will look to. Next is an adult child, followed by a parent, an adult sibling, grandchild, grandparent, and someone who is exhibiting special care or concern for you. So this is sort of the order. I was looking at this order and thinking about myself, and I thought, okay, my spouse, yeah, he knows what I want. He passes those criteria. And then I started thinking about my mom, and it's a good thing she's not here. I thought, gosh, my mom, does she know what's important to me? Yes. Could my mom make decisions in stressful situations? It's going to be harder for her. Will my mom honor my wishes and not hers? Oh, no way. And so, no way. So I even talked to her about it. I said, Mom, I'm not picking you. I'm picking my brother. I'm picking my husband first, and then my brother. And I explained to her why. I said, I love you, but it's good. I will be on a ventilator for the rest of my life, and this is not, and I will haunt you afterwards. So I explained to her why she was not my choice. So again, important things to consider. I'm going back just to this one slide that I apologize, I had out of order. There's a difference between these different forms. Has anyone heard of the POLST form? Do you mind raising your hands up? So it's a little bit less of individuals, but still a good substantial group of people that have heard of this. So this is an important form, excuse me, that I want to distinguish a little bit between an advance directive and the POLST. So an advance directive is your wishes where you think about future medical care. If you can't communicate for yourself, and you either have a written document, which is your living will that has these hypothetical situations, or you appoint an agent to speak for you if you can't speak for yourself. The POLST form is a physician's order for life-sustaining treatment, and it's a way for you to transfer your current preferences into a medical order. So now talking a little bit about the POLST form. It's not for everyone. The POLST form is really a method of end-of-life planning, and it has this specific set of medical orders. So it's really meant more for people who have the need for a medical order right away. It's built on conversations about, an immediate need. If you have a life-limiting illness now, if you have a chronic medical condition where, at any point there could be a decision that you might need to make about resuscitation or tube feeding or any of these decisions, not down the road, but they're really immediately there could be a problem. This is an important form to have. Again, it's only for people with serious progressive illness, limited life expectancy, and it allows you to have a medical order that really everyone should be honoring. It's not a do-it-yourself form. I think there are copies of the form that we can look at that as we go through. You can sort of look at them. So it's meant to be completed with your healthcare professional. It has treatment options that ask you, what would you want if you no longer have a pulse and are not breathing, and if that were to happen tomorrow, if that were to happen right now. Not again, 5 years from now, but if this were an immediate situation and you want to limit what your life-sustaining treatment options are, this is an important form to have. It also talks about treatment options when you have a pulse and are breathing. Would you want more comfort measures? Would you want limited interventions like going back to the hospital? Or would you want full treatment, which is like ICU level care? And so for people who want a limitation on their care, having this medical order is important because the default right now is full treatment. And so this can let you put some parameters on your care that will be actually followed.
Excuse me, how long do these last?
They're durable. They last as long until you rip it up or you decide that it's not something you want. That's an excellent, excellent question. So
Does your physician keep a copy of it as well?
they should. And so the question was, does your physician keep a copy? And the answer is yes, they should have a copy on your medical chart as well. And so I'm hoping not everyone rushes out to go and fill these out because you all look very healthy to me. So I'm not feeling like this is the right audience for the pulse form, but there may be people that in your lives that you think, hey, this might be helpful. You know, mom is she's in this age group. Resuscitation is not something she wants. If she arrests at home and someone calls 911 and this is not what she wants, then having this form, the paramedics are to look at this form and then follow what it says. Yes.
What about a car accident? Or would that be covered by your medical directives?
That's a great question. So if it's something like a car, the pulse may not be the best because if you want full treatment unless a certain situation happens, the pulse isn't as effective for that. It's more just how you want your care. So I think in a situation where you would say, if there's any hypothetical parts to it, if I had brain damage, if I had, completely disabled, if I couldn't breathe on my own, if you have caveats to your choices, I think your advanced directive are better to put that. But because the pulse form is more a medical order that people are following now. So you might be able to fill out actually a pulse form and put those caveats down to say, I want full treatment, but if I were in this type of situation, I wouldn't. It's more effective if it's for the immediate care than for future care, though. Yes?
Does the pulse designate a specific doctor, and do you need the accord of that doctor? And what happens in an emergency if that doctor is off in the Seychelles Islands or something? Is it automatic that it goes to another doctor? Or
You know doctors well because you know where they vacation. I'm just teasing. No, the pulse form it's your form to have at home or anywhere that you go to basically let emergency response personnel know what your treatment choices are.
Is there a method by which first responders will routinely look for that? Are there alert bracelets?
Absolutely, excellent questions. Oh my gosh, this is such excellent, rich discussion. Yes, absolutely. So first responders are trained to look for this form. It's typically, doesn't have to be, but does anyone know the color of these forms sometimes? Just to make it, I know Brett knows the answer to that one. Does anyone know what color they are? They're blue typically. So and again, it doesn't have to be blue, it can be any color. But the reason that they've been picked as blue is so they stand out. And so EMS are supposed to look for this form. Most people that have them, we kind of tell them, maybe put it somewhere where it could be found. So a lot of people will put it on the side of their fridge. I know this is a personal document, you don't want to have it advertised, but having it somewhere on the side of your fridge or if in your bedroom or a place in the home can be really helpful. I'm working right now, and actually Jamie's helping too, we're both going tomorrow to do beta testing to see about an electronic version. Because not everyone arrests in their own home. So what happens if you're at, Fresh Market or Whole Foods or Harmon's and you arrest? How do the first responders know if you may not be carrying this form with you? And so we're working on a way to actually link that so if people do have this as their choice, that they want limitations, that could be accessible, and a way to really make sure it's for the person who wants that choice so we don't make mistakes and identify it with someone else. Yes?
Would one way, like I wear a medical alert bracelet, could something like that be, say, just that a form exists or
Absolutely.
to
So in
medical
Utah,
alert?
from what I understand, that the statute does allow the medical alert bracelets. So those will be honored. So if you have and I need to double check on this, but from what I heard from the ePulse group, that the bracelet does actually work if people want that. The form works. Tattoos, not legal. So DNR tattoos, kind of interesting idea. Not going to work for you. And then just to kind of give you a few more details about the forms, again, it's meant a lot. It can be very helpful if you want to limit the type of care that you're receiving. So if you have strong feelings, and really think about it according to your values, and also think about it, what if it were temporary? So a feeding tube, some people say, no, I just don't want that, I don't want that. What if it were temporary? What if it were for a week, and you could have your exact same level of function back? And so, again, starting with the goals and thinking, and then thinking about the intervention. So if it could bring you back to your current level of health, if there would be minimal complications, would that be something that you would be acceptable? You might want to define trial period of time with that. If that's absolutely something, in no circumstances, no matter what, that you don't want, it might be worthwhile to think about this form and think about completing it, and then also having that discussion with your family members to really tell them what your wishes are. And again, IV fluids, if you have really strong feelings about that, resuscitation itself, if you have strong feelings. This being a not do-it-yourself form means you sit down with your doctor or your nurse practitioner, your physician's assistant, you have the conversation, they know your medical conditions, and you complete the form together. They should know what's important to you, your goals and values, and then you complete this. But any doctor, getting to the doctor in Seychelles, any doctor can honor this. So just a little summary again. Advanced directives are for everybody. Really anyone who's 18 and older should have one. It's instructions for future care. It doesn't guide emergency medical personnel. If the paramedics show up and you have do not resuscitate order in your advanced directives, they can't honor it. They have to take you to the hospital. It can guide inpatient treatment decisions. So once they get you to the hospital, the doctors can take a look at it and see what it says. And it needs to be completed by somebody who already has decision-making capacity. So if you have severe advanced dementia, that's not the time to complete these forms. You need to have decision-making capacity beforehand. Yes?
I'm going to ask you to rewind for a second.
Sure.
I'm still back at, if you have a DNR, do not resuscitate, they don't honor that?
If you don't have a medical order for it, it won't be honored outside of a licensed healthcare facility. So say you want to be DNR, you don't have a pulse form, you don't have a bracelet, if you just have said that to people and you arrest, the paramedics are responsible to do the most possible. So the DNR order is only, just because your advanced directive says I don't want to be resuscitated if such and such happens, that's not enough. It's not a medical order. It's not enough for the EMS. Does that make sense? I hope I'm not confusing the issue. Paramedics cannot look at an advanced directive and follow it. They have to go further. EMS, the paramedics, can look at a pulse form and honor it because it's a medical order. So if you have a do not resuscitate order on your pulse form, 911 can get called, they'll look at your choices, and they will honor it.
Is that nationwide or is that specific to Utah?
It's almost always nationwide. Almost every state has a way of having an order for this. Not every state has a pulse form. Some of them are called MOLST, or they're called different medical order for life-sustaining treatment. But there is a way almost in every single state to do that, but it might be different. Yes?
The point was made about CPR, and if you were given a choice, if 95% you were returned to your normal function versus, say, 20%. Yeah. Do you have and then the point was made about consult with your physician. I have a feeling a lot of physicians
may not know.
Exactly.
Okay, I'm going to teach you how to teach them. So this is one of my favorite topics because I actually teach this at the university too. Jamie had all these excellent quiz questions. What percentage of all people over 18 survive CPR to leave the hospital? What number would you guess that to be?
Teeny tiny.
Teeny tiny. What number can you throw a number to teeny tiny? It might be a little higher than you're guessing. It's a little higher than teeny tiny.
15.
1.5? Very close, 17%. So all comers, about 17%. That number again includes all comers. So that means if you're younger adults have a higher chance of surviving. People who are fairly functional, who don't have cognitive impairment. They're going to be closer to maybe a 30%. Older adults, so age over 65, any comorbid conditions, meaning other medical conditions, so heart failure, cognitive problems, functional problems, start to sort of shrink your numbers down. To me, the amount of people who survive is not as much, for me personally, I should say. If I live or die, I may say, well, give me a try. I'll live or I'll die. So, but that's not, that's not what happens. What happens is you can live, but not at the quality that you want. And there's the danger. So for me, giving it an attempt and I live, okay, great. Giving it an attempt and I die, oh, all right, okay, that's fine. I have my religious beliefs and everything's fine. There's this place in the middle that people aren't aware of where you live and it's not of value to you. If you live and you're in a skilled nursing facility and that's not of value to you. If you live and you can't recognize family. If you live and you can't put on your own clothing. And again, it's according to your own values. For some people, not being able to put on their clothing, living in a skilled nursing facility, but being able to recognize family, okay, that's acceptable. For my husband, I can tell you none of that's acceptable. Like, he keeps telling me, like, really, I want full function. I want to recognize people and be independent. So it's very individual based.
So how do you know in advance?
How do you know in advance what your chances are?
Yeah.
That's where there are actual some good information about who tends to survive and who doesn't tend to survive. And so that's some of the things that we're teaching at the University of Utah for our doctors to learn. And I can tell you, our new doctors that we're teaching now are getting that education, but your doctor may not know, to be honest with you, who survives and who doesn't. I shared some of that information with you. So the people who tend to survive tend to be the younger people, the people who have really good functional status to begin with, people who have really good cognitive status to begin with.
So if I'm 70, I probably shouldn't have CPR.
Well, and I would, just to be safe, I would say I would talk to your doctor about that, because you can talk about your age and your other medical conditions and, you know, your cognitive ability, which seems pretty good, and you don't look like you're 70 to me, so that's saying something as well. So I think that there's a lot of factors that you should have this discussion with your doctor and say, based on what you know about me, what do you think? Do you think this is something that is a good idea? And remember, your goals are the most important point. So you don't want to focus on, should I do it or not do it? You want to say, this is what's important to me. I want to live here like this. Do you think CPR will help me get there? Or do you think it won't? It'll take me on a different path. So it's remembering not to focus on the intervention, but focus on your destination. And then decide if CPR is the right choice to get you to that destination.
33% of us will die at home at this point. The rest are in some kind of facility. Okay, my father was in a nursing home. He got pneumonia. The facility transferred him to a hospital without ever asking anyone and treated him, and he had terrible quality of life after that. My aunt was in a facility. She got a urinary tract infection, and she was also transferred to the hospital.
Yeah.
When she came back to her facility, she needed a 2-person lift, and they wouldn't take her back. So I had to go and find her another nursing, a terrible quality of life after that. So can you just say something about dealing with facilities that most of us will be in, you know,
How many years ago was that? Was that recently? Just curious.
Recent,
Was it?
very recent.
One,
Because it's hard for people to say no about treating a UTI or a
Yeah.
pneumonia. You know, those are things, but the quality of life afterwards is just,
absolutely.
yeah.
Well, and that's Jamie's question about, you know, remember her, let's make a deal question.
Mm-hmm.
There's, and her slides about the tipping point. Are we prolonging life?
Mm-hmm.
Are we prolonging death? So thinking about that. When are we at that tipping point? Is treating this pneumonia, this urinary tract infection, going to prolong their life at a quality that is acceptable for your aunt, or is it not? And then this form would be important. And the other thing to say about the POST form that you have there is that if you are someone's surrogate, you can complete it for them based on their wishes. So this advanced directives have to be completed by the person themselves. POST forms can be completed for someone who no longer has decision-making capacity by who their surrogate is. So if you're the healthcare agent appointed for your aunt, for your family member, you can now, going forward, when they're in the facility, sit with the people in the facility and say, let's get one of these forms for my aunt. And in fact, many of the facilities now on admission are not requiring, but offering to complete this form with you. If you're there yourselves, they'll complete it with you. If a loved one is there and they can't make decisions, a POST form based on what they would want, not what you want for them, you can complete that and say, my aunt said this is what's important to her, so she would not want resuscitation. She would not want antibiotics based on what's important to her. And the form can be completed, and then if they're a good facility, which hopefully they are, if something happens, they should look to that before. Okay. And I want to be mindful of time, so if I'm happy to stay and answer questions, and I know Jamie is happy to join too. Can you let me know when we kind of need to, so that and again, it's not my time, but I want to be respectful of everyone else's.
So I'm just a little confused. We're
Sure.
saying that the POST is for people with serious, limited life expectancy, serious illness. However, at the age of 35, someone could be in a car accident, and a POST might be very important at that time. Would it not make sense to have a POST drawn up for just those types of things? You could be healthy, and all of a sudden, the unforeseen happens.
Yeah, I can see your point. The difficulty with the POST form, it's a medical order not based on hypotheticals, but for now. So that's where the challenge is. You know, it's not a form that says, hey, if X, Y, or Z happens, I want X, Y, or Z. That's more your advanced directive. But the POST form is, I want this treatment limited or extended right at this moment. And so that's where it's not based on any hypotheticals. It's really based on, if this were to happen tomorrow, what would you want? And that's the power of it. So I see how that could be very important. Yes?
How long do you think it will be before this approach will be uniform across all facilities and done in general in healthcare, as opposed to where we are now?
I love that question. And part of the reason I love that question so much is I work at, part of my university responsibilities is working at the VA, which is a huge national healthcare provider for a large number of people. We're actually working on creating a systematic approach to this. So we're training providers in how to have the discussion, because the art of the conversation is so important. Letting the doctors know how to have the conversation. And then we're creating a way that it can be found in the medical record, because as physicians we know finding things in the medical records can be impossible. So a way to really have it stand out in the medical record. So the training, the documentation, and then the policies that go through. So the VA is implementing that right now, and what I'm hoping is we've actually shared what the VA is doing with the University of Utah and with LDS Hospital, and we're thinking that they might actually catch on board and start doing something like that too. There's also an initiative in Wisconsin that's called Respecting Choices. It's more on the advanced directive model, but they have a whole systematic approach to documenting people's wishes. And what they found was making sure that everybody has the opportunity to say what their wishes are is really important, and making sure that we as healthcare providers honor it is really important.
But
So
it fits with Julie Jacobson's question from before. Between facilities and between different providers in
It
those
can get lost.
facilities, it always gets lost.
Yeah.
Uniformly gets lost now.
yeah. So it has to be a system. It has to be a system. It has to be durable. It has to be something sustainable, translatable across headings, absolutely. And so it's exciting because there's opportunities to work on this.
I assume there's no national registry where somebody can send in their either form, and an ER someplace could call in its place immediately and get their answer?
Not that I know of yet, but we are working, like we had mentioned, on that state registry for this. Jamie?
Karen actually had a really nice app for your phone where you can actually have all of this information downloaded onto an iPhone, so you have it with you all the time. It does require having, obviously, you're not going to be pulling out your iPhone if you're coding, but your family members would have, not having to carry that piece of paper. I think she had a bit.
Yes, I'm sorry, I apologize. I'd been facing this way.
What's really been, what bothers me about the pulse, particularly in the context of where you indicated early in your discussion, that goals is the first thing that you have to establish. The idea of signing this thing in a vacuum, without knowing exactly what it is that is before the physician and before the family and before the individual.
Excellent point.
It seems to me it's creating, I mean, it's a crapshoot, really, what you're doing, because in some contexts, it might be perfectly appropriate to say, don't provide any more treatment, just provide for comfort. In other circumstances, depending on what a person's goals are, it might be totally inappropriate to be doing that. So I find this form to be very disturbing, particularly where it is used in advance.
Well, and I think that's an excellent point, because in a vacuum, absolutely, you're right. And if we don't provide training for providers in how to have the conversation and what's important, and they just go through and, you know, do a checklist and they don't ask about goals, it's useless. It truly is. It's not a good document. But if it comes with that excellent conversation, people who know you, know what's important to you, and really, it can be very helpful. But it's just a tool. And so if the provider or the conversation isn't excellent, then the tool is not going to be. But if you have a great conversation, it could be a really helpful document. So I think it comes down to, are people adequately trained? And then just one quick other comment, and then I'll ask you to respond, is people have complained that if goals is the #1 thing, why isn't goals on that paper anywhere? And I agree with that. I think that if really going to what's important to someone and their goals is important, then we should reflect that on that document as well. It shouldn't just be treatment option and choices. It should have a place for patient goals. So there is some work to try to revise that to make it a better working document.
Just one other comment. I mean, it just strikes me that it's designed for the benefit of somebody who has to make a quick decision, a professional who has to make a quick decision, because I mean, it's just so easy for somebody to sign this thing and for a physician to sign it and not even get into those questions. And if this is something that's being used uniformly, without emphasizing what certainly makes sense to me is the extraordinary importance of individual goals, it's a terrible statute, and it's a terrible form.
Well, and to speak to that, though, it shouldn't be used that way. That's not the intent of it. So I don't want you to get worried. And it's also voluntary. No one can force anyone into completing this. So if you don't feel it reflects your wishes, then really, by all means, don't complete it. But I do think that it does serve a very important purpose for people that want to have, to verbalize their choices when it comes to end-of-life care. So, and I think the other thing that's very important is that the need for training. Like, that's why I teach at the University of Utah. That's why Jamie also volunteers to teach. We need to train our healthcare professionals about how to complete this in a meaningful way. So I see 2 more questions. I think one here, and the gentleman in the back had been raising his hand. And I'm happy to stay and talk with people afterwards as well.
The premise that you should have a conversation with your doctor strikes me as ludicrous. I mean, 14 minutes of time and 14 seconds of conversation. Having just taken a medical ethics class up at OSHA, you know, I'm left to wonder, why are we left to imagine our futures on paper? Will there ever be a moment at which our doctors are wise enough to know the answers to these questions and what's appropriate to do and not to do? Is there some place up at the U where we can go and have this conversation with, you know, not the doctor who has 14 minutes, but with some counselors and folks who have the big picture, and spend that kind of time? I mean, I've been handed this form probably 3 or 4 times over the last number of years, and I'm left just completely befuddled. I want, if shit happens and it's fatal, I want to die. And I want the doctors to be empowered because they're the ones who know. You know, you're the one who knows the statistics and the odds and the prognosis, and no amount of paperwork is going to convey the possibility. Just, again, where's the piece of paper, like this gentleman said, that here's the end result I want, and if I'm not going to go there, then all right, just enough already.
Yeah. I think you brought up some really important points, and I think one of them is time. And so I know there's some legislation that's out there to actually give physicians time to have these conversations so that they can, you know, we're very procedural based. It's very much like you get your mole taken off and you get reimbursed, and it favors having these quick visits like that rather than to sit down, get to know your patient, talk to them. But so there is some movement and some legislation. I think there's 2 or 3 bills to try to actually encourage doctors to have time and to be able to take time to answer these questions. So from a systematic standpoint, there's some movement towards that. Just a plug for geriatricians. We are oftentimes given more time. So, you know, that's something to consider. If you have a loved one that is older that needs more time, potentially seeing a geriatric specialist, not always, but can be a really good way to have a little bit more time. Palliative care, as Jamie said, is a whole specialty that can, if somebody has chronic serious illness, those are those specialists that you asked about that can sit with you and talk and share this information. So if it is appropriate, looking at a way to connect yourself or whoever you're thinking of with palliative care, oftentimes that venue does have time. So we're working towards a solution. Of course, we're not there yet.
So I will see my question to you.
Oh, okay. I've been putting up my hand for you, but anyway, I think it may be similar. You've said several times about the medical director speaking for you when you are no longer able to speak for yourself. But in my understanding, if you have dementia and you specify while you are in sound mind that you want an assisted death, then when you have dementia, that cannot be honored because you have to be of sound mind to say, I want to have an assisted death. So how do all these things relate to people with dementia?
The assisted death question is a really interesting one because right now somebody who's cognitively, so it's only legal in a few states, the assisted death, the physician's assisted suicide or death with dignity is called some other places, is not legal in Utah currently. It is in Oregon, Washington, Wyoming, I believe, and one other state that I can't think of. Was it Vermont? Vermont. Because of worries about the ethical implication of that, it can only be physician assisted. You have to be able to take the medication yourself. So in someone who has any sort of cognitive impairment, that is out of the question, even in the states where it's legal, because it's not, the physician's assistance portion of it is that you write the prescription for the medication that the patient then takes themselves. So really, in anyone who could not have the capacity to make the decision to do that, they have to know what it is and take the medication. So it's just not available at this time, even in the states where it's legal. Does that make sense?
Yeah, well, I do understand. It
Yeah.
doesn't make sense to me whatsoever, but I understand that is a law.
Yeah.
But then I have a follow-up question. So how does palliative care and hospice then work for people with dementia? Because my understanding is that you can never say with dementia you'll be dead in 6 months. So then you cannot have hospice care. And I've recently been reading that of cases where people with dementia have asked their families when they were making the medical directives that they wanted to die by stopping food and eating. And then their families, it needs a very cooperative family, but when that happens, their children would they would several times say, I don't want to live anymore. Their children would then remind them that is what they said, and every time, and follow through with that plan. And every time they want for something to eat or drink, they can say to them, I'd be happy to give it to you, but do you remember that this is what you're doing? And so that is a way then to start starving yourself so that you can get organ failure. And once you have organ failure, you are eligible for hospice care, even with dementia.
That's lots of components to that. It's a little hard to know where to begin. So starting off with the dementia and not knowing when they're 6 months or less, I actually would, as a hospice physician, I think there are times when you can actually say that there is 6 months or less for dementia. Jamie touched upon it on her slides when she was talking about the she talked about the trajectory, was one of the words that she had in her slides. If you start noticing that people are rapidly having a decline in their functional status, dementia patients who are losing weight really quickly, who went from being fairly independent to needing a lot of assistance, these are all indicators that hospice would be an appropriate thing. Somebody who's ambulating, walking around independently, and then can no longer do that. So, and it's the rate of decline. So if it's over this gradual period of time, yes, okay, we're not so good, we can't tell. If somebody is having a really rapid rate of decline, even with dementia or whatever it is, I would definitely say that this is a hospice appropriate patient. So I do think there are ways for us as clinicians to understand when somebody has 6 months or less. When it comes to people choosing not to eat, again, if they have capacity, if this is not out of a depression, if they have a terminal illness, ethically, from what I understand in the hospice and palliative medicine community, we can honor their choices. If, again, with a lot of caveats, they're not depressed, they have capacity to make this decision, all of those things we'd have to check, because if it's out of a depression, we'd want to treat that. But if that's their choice, they have a terminal illness and this is sort of their choice, that can be honored. We have patients who that's sort of what they choose. The other thing is, some people don't choose that, but it happens naturally. There are many people who at the very end of life no longer have an appetite. And so we try to do education with families to offer food and nutrition, but not to force it. And so that's, I think, where we just really want to offer people. We don't want anyone to feel starved or to be hungry or not to be comfortable. So we want to be respectful of that. And then there's the side where people are force feeding patients, and we just try to really educate them and help them understand if food is no longer a comfort, let's try to look for other alternatives for comfort for that patient. Could it be music? Could it be massage? Could it be pet therapy? What is it that brings joy and comfort to their life, and let's honor that. I'd like to just close with a quote. Jamie has one that I'd like to read for you as well. But this is one that I saw at one of our medical conferences, and it just spoke to me. It says, once we insist treatments are mandatory in all circumstances, medicine becomes less of a servant of humankind and more a master. And that really resonated with me, that really the idea of picking our path, picking the treatment, the circumstances where we feel it's beneficial, that's so very important. And then I really like this that Jamie also included for closing of our conversation. The tools of modern life-saving had forced upon him the suffering of life without its joys and the helplessness of death without its peace. This is not what we're looking for. We're looking for people to create their own roadmap, to really, again, the form is just there as a tool for you. If you don't feel that it's with a valid conversation, if you don't feel the person who's completing it knows you or your loved one, don't complete it. By all means, it's a tool to help you. But if you feel you had an excellent conversation, they understand you and your goals and your prognosis, it's a mechanism that can help honor that. Thank you for the excellent question.